treatment. This is a SL10 catheter with manually pigtail shaped. And after insertion of the wire, after 5 times, after 10 times, you can see that SL10 is stretching out. So how about pre-shaped JSL10 catheter? Even with pre-shaped catheter, you can see that the shape is stretched after inserting the wire 10 times. So this is the headway 17 catheter. The pigtail shaping maintained even after multiple insertions, even more 10 times. So based on these findings, we believe that the headway 17 catheter is recommended when strong shaping is required. And this is the basic strategy how to shape the microcatheter. A simple support is provided on the contralateral vessel wall. And the microcatheter is inserted along the long axis of the aneurysm. After bending, it is best to adjust the length of the microcatheter so that the tip is in the middle of aneurysms or about the proximal third. However, the microcatheter sometimes does not point in the desired direction. In this case, pre-shaped 40 catheter was selected first, but it didn't fit the aneurysm. After that, I shaped manually S configuration. The shape was stabilized at the 2 points inside the parent artery, like this, and the tip was inserted along the long axis of the aneurysm. This is another tips. The bending the tip of the microcatheter about 1 millimeter towards the aneurysm, center of the aneurysm, reduces the risk of perforating aneurysms at the end of the endovascular procedures. This is an example of coil embolization for ICPC aneurysm. And you can see the tip of microcatheter is still heading toward the aneurysm at the end. This is another example of web placement. And you can see that the catheter tip is pointing towards the aneurysm from the beginning. This reduces the risk of perforating the aneurysm when starting to deploy the web, like this. Next, we will explain how to shape the microcatheter, especially for paracrinoid aneurysm. Pigtail shape is suitable for medially projecting aneurysm. If the aneurysm is projecting three-dimensionally, the microcatheter is also needed to be formed three-dimensional pigtail shape. This is a case of medially projecting paracrinoid aneurysm. In this case, we shape the microcatheter into three-dimensional pigtail catheter. In these cases, the microcatheter is often kicked out of the aneurysm. Therefore, it is necessary to stabilize the microcatheter with a balloon. The S-shaped microcatheters are useful for upward projecting aneurysm. And if the aneurysm has a three-dimensional axis, we have to make a three-dimensional S-shape. This is a representative case of upward projecting aneurysm. In this case, two-dimensional S-shaped catheter was suitable. So next important basic technique is how to select and how to protect the branch. This is a case presents an ICPC aneurysm with a relatively wide neck. The microcatheter is advanced into the PCA to place a stent. A mini pigtail-shaped microcatheter was hooked on the branch, and the wire was guided into distal PCA. If the pigtail catheter pointed in the opposite direction on the intended direction, a reversed curve is made in the proximal end, which will then point in the desired direction. It is also a good idea to use an equivalent pre-shaped S-shaped catheter like this. This is a case of MCA aneurysm in which a pre-shaped S catheter was effective to select this superior branch of the MCA. So next, I will explain how to protect the branch. To protect the branch, it is best to bring the microcatheter close to the branch like this with a balloon. This will prevent the coil from interfering with branches, and this can create good frame. Next, I will talk about intersacral device, the latest treatment for bifurcation aneurysm. First, I would like to explain two advantages of intersacral device. In the first half of my presentation, I explained how to select the branch. However, when we use intersacral devices, we do not need to select branches. And another strong point is about antiplatelet therapy after treatment. We can stop dual antiplatelet therapy immediately after wave plantation. Therefore, intersacral devices are useful in treating elderly patients because they have much risk of hemorrhagic complication compared to the young. This graph shows the changes in endovascular treatment for unruptured bifurcation aneurysms in our hospital. Due to the two positive factors mentioned before, over the past 2 years, stent-assisted coiling has decreased, and instead, treatment using intersacral devices has increased. Go like this. Of course, there are some tips and pitfalls when we treat aneurysm with intersacral device. I explained before that the antiplatelet can be discontinued shortly after treatment, but there are exceptions. In cases where the intersacral device protruded more than 50% or more into the parent vessel, we do continue long-term antiplatelet therapy, just like with stent-assisted coiling. Also, when a stent is needed to add it to our intersacral device, we also use long-term antiplatelet therapy as in stent-assisted coiling. And there are some cases where coiling is still considered a better option as follows. Aneurysm with a narrow neck and a deep cavity. Aneurysm on branches with small branches or with reversed angle branches. And the aneurysm with a bleb near the neck. I will show you some examples. For aneurysm with narrow neck and deep space, it is difficult to place intersacral device at the neck surface. And enlargement of neck may be occurred during follow-up, like this. So therefore, conventional coil embolization seems more appropriate in such cases. This ACOM aneurysm is on the right side S branch, and this S branch has a reversed angle. Intrasacral device was easy to protrude to the parent artery, and thrombus occurred. So intrathrombus thrombosis is very concerned in such cases. Here is another example. This aneurysm was on the inferior branch, and thrombosis was observed, so device had been changed to a smaller one. In this case, the intrasacral device couldn't fully seal the neck, so blood flow persisted into the brave, which led to rupture after procedure. So this is a take-home message about the basic techniques. The headway 70 catheter is recommended when strong shaping is required. A bending tip 1 millimeter into aneurysm is safe. About selection and protection of the branch, a pigtail-shaped and S-shaped catheter is useful to select the branch. The balloon sometimes stabilize the microcatheter towards the branch to be protected. About cutting-edge treatment, intrasacral devices are useful when difficult to select branches. Intrasacral devices are useful in treating elderly patients. But there is some pitfalls. Coiling remains an option for aneurysm with a narrow neck and deep cavity on branches with small branches or with a reversed angle and with brave near the neck. So thank you very much for attention.
Thank you, Professor. So great, interesting cases and very useful tips from your experience. And yes, I would like to ask from discussants to ask some questions or any your any talk, please.
Can I ask some questions, Professor?
Yes, Professor, it's okay. Yes.
Tomo-sensei, thank you so much for your beautiful lecture. Actually, that bending of the shaping like microcatheter is very important, but sometimes very kind of difficult for young neurosurgeons to begin with because they have to know how they can, imagine the shape after, removing the mandrel. So my question is, do you recommend using steam shape or heat gun? And if you use heat gun, then what is the temperature you recommend?
I always use a heat gun with 150 degrees Celsius for 1 minute.
1 minute.
It's my routine. Yes.
Okay. And then do you have any specific distance from the tip of the heat gun to the microcatheter?
I'm not sure. It's very difficult to say, but I use 10 centimeter distance. We hit the microcatheter from the tip of the heat gun.
Okay, thank you. And I have actually another question. So you mentioned the intrasaccular device, and it's very promising device, I guess. But in Japan, currently only web is available, and since size variation is kind of limited in Japan, so sometimes we may experience there's no suitable web. So let's say we prepare everything so we can implant the web, but we may have to come back to stent coding or something. Is there any cases which you have experienced like that?
Yes, as you said, very small aneurysms such as below 4 millimeter or something, it is difficult to put web so far. But in the near future, we have web 17, and at that time we have several lineup below 4 millimeter. So we very promising new type of web. And yes,
Okay, we are waiting for that. Thank you.
yes.
So yes, I would like to also invite Professor from Ukraine, Professor Alexander Wozniak. If you have any questions, please. Or we have also distinguished discussants from Japan, Kostadin Karagizov.
Thank you, thank you for the good words. Thank you very much, Professor Tsumoto, for the very highly instructive lecture. I think this is an excellent lesson for all starting and initial stages of endovascular neurosurgeons. It is really very valuable, practical information that you have given. I have very few questions practically, but just to add a small comment on the shaping of the catheter intraoperatively, it is really sometimes requiring a lot of imagination from the surgeon how to shape it. And in Japan particularly, as you know, Dr. Ishibashi, we made a 3D printed model, which is sterilized. And the catheter can be shaped intraoperatively according to that. And that proved to be very useful intraoperatively. Otherwise, I have very few questions. First of all, the positioning of the catheter, do you have any special recommendation to the young neurosurgeons when the shape of the aneurysm, particularly with multiple blebs and so on, how really safe and protective you will be with the placing of the catheter? I will just add that the having a balloon at site, particularly in difficult aneurysms, will help in case of, well, God forbid, rupture. This will be very protective, so it will be really solving the matter. And particularly the intrasaccular part, using of webs, how do you find the long-term results and in how much you can be flexible in the selection of web? Do you have any difference in the recurrences that you can recommend when using webs and coiling, particularly techniques in these locations? This is my comment, and thank you for the long talk.
Thank you very much for your comment. We have a web from 2021 or something, so we have a very short experience so far. So we don't have a longer experience. But according to European experience or something, web is not so bad compared to coiling or stent-assisted coiling. And wave is very, procedure time is very short. So I think the web is very useful for elderly patient and so far, yes. Thank you very much.
Thank you very much. Yes, thank you.
So thank you, Professor. Thank you for our speaker and the discussants. And then now we are open the floor for questions from the audience, please. If you have any questions, please, you can type to the chat box and we'll direct them to our speakers. Please, any questions from audience?
Yes, one is raising hand. Doctor,
Yes.
and yeah.
I can figure it out.
Dr.
Yes.
This is hand.
So
Maybe
Professor, okay. Yes.
Go ahead with your question.
Okay.
Yes, you can.
Thank you.
Thank you. Thank you so much. Thank you, Professor, for this presentation. In a part of the world, we don't hear so much about endovascular. We don't do endovascular treatments. So it's interesting to hear this rich presentation. It's really expository, and I so much appreciate. Thank you so much, Professor.
Thank you.
Yes.
I would like to ask a question, Prof. Tsumoto. I think for the YNS, web device and intracellular devices are, say, not commonly available, especially from where I am here in Malaysia. What type of aneurysms would you suggest as a beginning type of aneurysms to start off using the web? That was the first question. And there are many people who advocate the web device for MCA bifurcation aneurysms. But the literature usually says that clipping is the gold standard for it. What are your opinions on that? Thank you. Thank you.
In my opinion, the situation of the aneurysm is not concerned. For a beginner, I recommend aneurysm such as 5 or 6 millimeter diameter aneurysm, the middle sized, and straightforward aneurysm to the dome. So not acute angle. Acute angle is not recommended because that is very difficult to put a web for beginners. So straightforward aneurysm and 5 or 6 millimeter in diameter. In that case, the beginner should begin with web treatment. I think so. Okay, right. What about clipping versus web for MCA bifurcation aneurysms? I actually do web implantation for MCA aneurysm. The site of aneurysm, it doesn't matter for me. Right. Sorry. Okay, thank you so much.
So I think if there is no any questions, I would like to also ask one question, Professor, about if you see any high risk of recanalization near the neck, and what's your plan for follow-up, like, and what kind of like MRI or CT, what do you recommend? And if you, and the second question is, for example, after web or after coiling, if you see a small part of near the neck, very small part, do you try to like fully embolize it, aneurysm, or you can just follow up like a couple months or a couple more years? So yes, this is a question. So about the first question, I do MRI follow-up every 3 months, and I do angio 1 year after web treatment. About the second question for a very small remnant, in my opinion, the small remnant is very low risk for rupture. So I just keep follow-up for that patient. I see. Okay. Thank you so much, Professor. Thank you very much.
Actually, we have Professor Wozniak in the panelist, and if you have any comment or question, Professor, it's yours.
Okay, thank you. I'm sorry, I was switched off and couldn't speak before when you invited me. Professor Tsumoto, thank you very much for great talk, very practical and very, I think, very useful for neurosurgeons, for endovascular neurosurgeons. I'd like to ask you about, I have one question. I have no big comments, but what is your tactics in patient with paraclinoid aneurysm with neurological deficit, with visual deterioration or with third nerve deterioration? Would you consider open surgery or just think about endovascular also as well?
I prefer to put Freud diverter first, for such cases.
Mm-hmm.
Yes.
Yeah. Okay. Great. Thank you.
Thank you, Professor Alexander Wozniak. Thank you.
You're
We
welcome.
didn't notice you are joining us.
Yes,
So
I'm with you. I'm joining.
Thank you. Yes, I think we can. If there is no any questions, we can turn to the second speaker. So, second speaker, let us now proceed. And I'm pleased to invite Dr. Febby Pratama Kusuma from Indonesia, who will speak on neuroprotective and the neurorestorative effects on adipocyte-derived mesenchymal stem cells in traumatic brain injury. So, Dr. Kusuma, we look forward to your talk. Yes.
Okay, thank you so much, Doctor. Does my my presentation already appear and my voice clear?
Yes, we can see
everything is okay.
Okay, thank you. So, good evening, Professor and doctors. It is a great honor for me to have this opportunity to share one of my recent studies with the title Neuroprotective and Neurorestorative Effects of Adipocyte-Derived Mesenchymal Stem Cells in Traumatic Brain Injury. So, before I begin, please allow me to briefly introduce myself. And my name is Febby Pratama Kusuma. You can call me Kusuma. I come from Bali, Indonesia. I believe some of you may have already visited Bali, but for those who have not yet traveled there, I would warmly recommend it because Bali is a beautiful island with many wonderful destinations such as Seminyak, Ubud, Sanur, and Uluwatu. And I am a lecturer at the Faculty of Medicine, Universitas Udayana, Bali, where I teach both undergraduate and postgraduate students. In addition, I also serve as the managing editor of the NSMC journal. For those who enjoy expressing their ideas through scientific writing or perhaps contributing by reviewing manuscript, our journal would be an excellent platform to collaborate. Alongside my academic duties, I am continuing my training as a neurosurgical resident in Neurosurgery Study Program, Faculty of Medicine, Universitas Udayana, Ngurah Hospital, Bali, Indonesia. So during this period, now I'm in my final semester of my residency. So during this period, I have been granted the opportunity to study abroad with the support of my mentors in Bali, Professor Sri Maliawan and Professor Cokorda Gede Bagus Mahadewa, whom I respectfully consider as my academic parents there. And at present, I am truly honored to be part of the neurosurgical fellowship at Fujita Health University, Bantane Hospital, Japan. On this special occasion, I would like to sincerely express my deepest gratitude to Professor Yoko Kato Sensei, whose kind support has helped transform one of my dreams into reality. So let me begin with the introduction. So traumatic brain injury until now has still become the main cause of morbidity and mortality worldwide, mainly on the developing countries. So the pathologic process starts with the primary brain injury, where the neuron, glial, and vascular damage due to mechanical force to the brain. After the neuron and glial damage, those damaged neuron glial will release inflammatory cytokine, which in turn will cause neuroinflammation, excitotoxicity, oxidative stress, and cell death. And if it's uncontrolled, it can cause secondary brain injury, which is the worsening of traumatic brain injury due to this complex injury mechanism. In the end, there will be cognitive and physical disturbance, reduced quality of life, and mortality. That's why an intervention to prevent the secondary brain injury is important. And recent studies found that adipocyte-derived mesenchymal stem cell has the potential to overcome these problems. So secondary brain injury can trigger a series of events that worsen morbidity and mortality in TBI patients. Thankfully, secondary brain injury is therapy sensitive and preventable, providing a therapeutic window that can determine whether the traumatic brain injury recovery outcomes are favorable or poor. If secondary brain injury is not controlled, it can exacerbate the TBI morbidity, leading to cognitive, motor, and psychological impairments and even death. Therefore, appropriate management to prevent secondary brain injury is crucial in TBI as it can reduce post-TBI mortality and disability rates. The ideal management of secondary brain injury following TBI, there were two strategic approaches in combination. So the first one is the neuroprotective approach, which the target is the injured area of the brain. It is expected to reduce or prevent the secondary brain injury and neuronal cell death and prevent the expanding of the lesion size. And the second one is neuroregenerative approach, which it is expected to enhance the neurological recovery, treat the entire CNS, and promote neurovascular remodeling, which in the end will stimulate angiogenesis, neurogenesis, oligodendrogenesis, and dendritic or axonal growth. So therapeutic modalities for TBI management are being extensively investigated, and one of them is stem cell. Why stem cells? Because in general, previous study found that stem cells has multipotent capacity, which allows differentiation into specific cell types, including neuron and glial cells. They also have self-renewal capacity, which makes them as a potential neuroregenerative agents in TBI. They also have neuroprotective capacity, which prevent neuronal cell death in TBI. So from many types of stem cell, we chose adipocyte mesenchymal stem cell because adipocyte is more easily and more readily available to harvest, and it has less ethical problems. So this hold promising potential as therapeutic option for the management of TBI. That's why we investigated adipocyte-derived mesenchymal stem cell-based therapy in experimental TBI animal model. This was the methods. We use pure experimental randomized control group design. So from the samples we achieved, we split the samples into control and therapy group. The control group, we provoke the samples to become TBI by weight drop procedures. And after that, on the control group, we inject intracortical injection of normal saline with the volume 40 microliters. And then we split into two arms. One arm terminated on the day 7 post-injury, and the second arm was terminated on the day 14 post-injury. After the termination, we look for the output is BDNF levels, which we measure it through the ELISA assay. And the second one is apoptosis index from the tunnel assay. And the last one is cognitive function from the Barnes-Maze evaluation. And the therapy group, after we provoke the samples to TBI, we inject intracortical injection of 200,000 adipocyte-derived mesenchymal stem cell. We also divide the therapy group into two arms. One arm terminated on the day 7 and another arm terminated on the day 14. We also look for the same variables output, which are BDNF level, apoptosis index, and cognitive function. And the results and discussions. So firstly, before we provoke the samples to get TBI, we evaluate the cognitive function pre-TBI by the Barnes-Maze procedure. So total we got 30 samples, which consisted from 14 samples therapy and 16 samples control. From the Barnes-Maze evaluation, so both group, the therapy and control group, can escape from the Barnes-Maze. We measure the time in second, and there's no difference between groups. no significant difference between groups at the start of the study, so it can be concluded that both samples were homogeneous pre-TBI. And we follow the protocol. We give the control group, we provoke them to TBI and inject intracortical normal saline, and the therapy group, we also provoke to be TBI and inject intracortical stem cell. And then before we terminate, we evaluate the Barnes-Maze evaluation to get the cognitive function. And after that, we terminate every samples on we have one arm on the day 7th post injury and another arm on the day 14th post injury. So the first thing the first thing that we evaluate is the brain tissue microscopic image. This is actually one of the most surprising thing for me as when I studied this. So the A image is the therapy group on the day 7 post injury. This image show that there's brain tissue restoration within the brain injury area and has the similar color with the healthy brain tissue with minimal brain tissue necrotic, encephalomalacia, and atrophy. Then we compare to the control group, and the B image is the control group on the day 7. It shows no brain tissue restoration within the brain injury area and also broad brain tissue necrotic and encephalomalacia. Also, on the day 14, the image C is the therapy group on the day 14. It showed brain tissue restoration within the brain injury area, as similar as the healthy brain tissue, include the vascularization. And the brain injury lesion area is getting smaller, and also minimal brain tissue necrotic, encephalomalacia, and atrophy. And compared to the control group, on the day 14, show no brain tissue restoration within the brain injury area, and also it has broad brain tissue necrotic, encephalomalacia, and atrophy. And then after we evaluate macroscopically, we would like to know microscopically. So the first thing is the brain apoptosis index. From the tunnel assay, we found that apoptotic index between groups are significantly different, and the therapy group has smaller apoptosis index compared to the control group in both occasions on the day 7 and 14 post-injury. So the brain apoptotic index on the day 7 and 14 in TBI male Vista rats with ADMC therapy group is lower compared to the control group. This is the image, the histologic image of the brain apoptosis index.
Sorry. The slide is not showing. Yeah.
Sorry. Wait, let me.
It's on your first slide. Yeah.
Let me reshare it. Wait.
Right.
I think from the macroscopic, it's not appear. So let me repeat. This is the brain tissue macroscopic image. Is it already appear? The presentation? Not yet?
No.
Wait, let me repeat share screen.
Yeah, okay. You can put full screen. Yeah, okay.
I'm sorry. Maybe there's a problem from this slide. So the result, this is the result, the brain tissue macroscopic image. So the A image is the therapy group brain on the day 7. So it showed brain tissue restoration within the brain injury area, which is similar color with the healthy brain tissue, with minimal brain tissue necrotic, encephalomalacia, and atrophy. And then we compare it to the control group on the day 7th, which show no brain tissue restoration within the brain injury area, and also broad brain tissue necrotic and encephalomalacia. The A is the therapy, the B is the control on the day 7. And then continue to the day 14. The C is the image of the day 14 on the therapy group. It showed that brain tissue restoration within the brain injury area and also as similar as the healthy brain tissue and includes the vascularization. And the brain injury lesion area is getting smaller with minimal brain tissue necrotic, encephalomalacia, and atrophy. And then compared to the control group on the day 14, it showed no brain tissue restoration within the brain injury area with broad brain tissue necrotic, encephalomalacia, and atrophy. So after we evaluate macroscopically, we would like to know how is it microscopically. So we evaluate the brain apoptosis index, and we found that the apoptosis index between groups are significantly different, and the therapy group has smaller or lower apoptosis index compared to control group on both occasion, on the day 7th and the day 14th. So this study found that brain apoptosis index on the day 7 and 14 in TBI male Wistar rats with adipocyte-derived mesenchymal stem cell therapy group is lower compared to the control group. This is the histologic image. The A is the control group on the day 7. The B is therapy group on the day 7. The control group has more apoptosis bodies. And also on the day 14 is the same. The control group has more apoptosis body compared to the therapy group. So this study proved that adipocyte-derived mesenchymal stem cell therapy suppress apoptosis and promote regeneration. It strengthened the previous study, which found that ADMSC therapy acts as a neuroprotective agent to prevent apoptosis and maintain neuron survival post-TBI. So secondary brain injury is involving complex injury mechanism, and adipocyte-derived mesenchymal stem cell therapy can suppress neuron apoptosis due to its neuroprotective properties by suppressing the secondary brain injury complex mechanism, include excitotoxicity, neuroinflammation, and oxidative stress. So the suppressed secondary brain injury will in turn cause a prevention of blood-brain barrier damage, edema, ischemia, apoptosis, neurodegeneration, and functional deficit post-TBI. Thus, ADMSC therapy does provide promising potential as TBI treatment because it has two properties. The first one is about neuroprotective, where through the apoptosis index, we can find that it can suppress cell death. And also as neurorestorative agent, we can find that macroscopically, it causes the brain growth. And we evaluate the BDNF level. Actually, we expect that there will be difference between groups, but this study found that there's no significant BDNF difference between groups. So evidence show that there's no BDNF difference between groups. Actually, it a bit contradictory from previous studies because previous studies found that adipocyte-derived mesenchymal stem cell will increase BDNF expression, thus improve cell survival and regeneration post-TBI. So we searched that we found, previous study found that BDNF gene methylation, traumatic brain injury can cause BDNF gene methylation post-TBI, which in turn it will inhibit the BDNF gene transcription in both groups. So another study found they analyze the level of BDNF and NGF through RT-PCR. So they found that adipocyte-derived mesenchymal stem cell has a higher BDNF and NGF gene expression compared to normal swan cell. But after they confirm it with ELISA analysis, only NGF protein that is significant. So for the next study, we can consider RT-PCR can be considered to confirm the BDNF level study from ELISA analysis. Also, from the sampling time factor, Previous study found that BDNF mRNA expression is increased within the first 24-hour post-TBI, and then after 24-hour, the BDNF level will decrease and not significant after 36-hour post-TBI. However, based on the brain tissue microscopic result in the study, it is proof that cell proliferation and brain tissue remodeling are running steadily and durable in the therapy group compared to the control group. So another variable that can be evaluated next, because not only BDNF, the adipocyte-derived mesenchymal stem cell also secrete other brain neurotropic factors such as NGF, neurotropin 3, and neurotropin 4-5. And NGF also has crucial role in neuroprotection post-TBI and mediates nerve tissue repair through neurogenesis induction. And secondary brain injury mechanism post-TBI also include many factors, not only BDNF. That's why we can evaluate such as, oops, is it still okay? The screen still appear?
Yes, it's there.
Yes.
Okay, all right. So we can evaluate interleukin 6 and TNF alpha because previous study found that ADMSC can suppress interleukin 6 and TNF alpha, also suppress the GFAP and IBA1, and also prevent neuron apoptosis through the new expression protein, and also suppress nitric oxide in cell culture model. And the last variable is cognitive function from the Barnes maze. We found that the mean Barnes maze escape time between groups are significantly different. The therapy group escaped the Barnes maze faster compared to the control group in both occasions, the day 7th and the day 14th. So the study found that cognitive function on the day 7 and 14 in TBI male with a rat with ADMSC therapy is higher compared to the control group. So the study proved that ADMSC therapy can restore cognitive function post-TBI. It strengthened the previous study, which found that ADMSC therapy can act as a neurorestorative agent to improve neurologic recovery and promote neurogenesis post-TBI. So it is proved that ADMSC therapy prevent complex injury mechanism in SBI. It will in turn cause early initiation and maximization of the neurorestorative process. And in the end, it will make the cognitive function restoration post-TBI. And previous study found intracortical injection of ADMSE will improve the motoric function through the Rotaro test. And also the injected ADMSE can be identified at the perilation area in the brain and increase hippocampal cell density and neurogenesis. And also, ADMSE therapy can increase neuron expression, which is a mature neuron marker, and also increase neurologic function restoration through the modified neurologic severity score. And in the end, ADMSE therapy can prevent neuronal apoptosis through the apoptosis index, also promote neurorestoration and improve cognitive function post-TBI. So in conclusion, intracortical adipocyte-derived mesenchymal stem cell therapy in male Ratus norvegicus post-TBI can act as a neuroprotective agent by suppressing brain cell apoptosis, as well as acting as neurorestorative agent by improving cognitive function post-TBI. Saying thank you. It's the end. Thank you.
Okay, thank you. Thank you, Dr. Kusuma, for very informative preclinical study. It's a very good job. And I would like to again invite our distinguished professors, Professor Wozniak, Professor Karagiozov, please. Please, any comments and insights from you?
Thank you. Dr. Kusuma, my congratulations. Really great job. You know that the brain trauma, traumatic brain injury, it's a field of neurosurgery which had minimal progress during last decades comparing with other fields of neurosurgery. And any result, any effort in direction to improve the results of TBI management must be supported, and your activity is really must be prolonged, and I wish you to overcome a lot of obstacles and the limitation to the way of clinical implementation of this method in the future. So my congratulations. Great job.
Thank you, Professor. Yeah, I'm in my center actually. Traumatic brain injury still be the main problem in neurosurgery field because a lot of patients came because of traffic accident. We have high amount of traffic accident. That's why in my center, we focus on neurotrauma and neurointensive care. And this is one of the main topic that is elaborated in Bali. And also, yeah, I agree that stem cell therapy has a lot of obstacle when we want to convert it to clinically. But in my country, our Indonesia have an association of stem cell group called Reja Celindo. So they promote stem cell based, cell-based therapy. One of them is stem cell to overcome many problems available in the country. So one of them, so I try to implement the government program and also our center program, the stem cell and traumatic brain injury. I have to start the study preclinically, of course, to make sure that it is effective. And I hope soon we can start clinical study. First, maybe from the toxicity. Thank you, Professor.
Yes, and I wish you success, big success in clinical implementation. And thank you.
Thank you.
Thank you, Professor Wozniak. So any comments, Professor Karagiozov, please?
Thank you very much for the very interesting presentation. This was really a very good choice because adipose cells are those which we can harvest and produce maybe in the easiest way for stem cell treatment. First, I would like to ask a question. How long is the time between the induction of injury and the application of the stem cell substance for specimen? How long is the time between the two?
Yeah. So it's 1 day period. So we make or provoke the mice injury on the day one, and then we close the wound, and then we wait until the mice recover. The next day we inject intracortically the stem cell and the normal cell under control. Thank you.
And that's in the same place of the direct injury.
Yes, the same place. Perilational.
There were clear contusions on the mice brain, so injecting the same place.
So after the brain injury, there is a contusion. We inject the cell perilation.
Besides,
Yeah, perilation. Not in the center of the contusion, but perilation.
I see.
Yeah.
Okay. Thank you for that reply, because these are very important things. I mean, the timing is very important really for the future of clinical application. This is a momentous damage which we have to intervene as early as possible. I would like just to have your comments. How do you see the effect? You mentioned some of the substances which probably from the stem cell culture really interact with the brain tissue around, but what is the probable mechanisms? The stem cells produce multiple factors, molecular factors that will interfere with the protection. I will not say even regeneration because the period is relatively short. But how do you see which substances are most probably the most important? And do you see anything kind of genetic induction in this moment? Do you think that the RNA, which these stem cells provide, they produce actually, this is a very important function they have, is interfering with the recovery? Because this really makes the process much deeper and with much better perspective in the long term. How do you feel that?
So,
How do you see it?
Yeah, thank you, Professor. So I would like to explain. So previous study found that adipocyte-derived mesenchymal stem cell can suppress interleukin-6, 10F, and also 10F alpha. Yeah, we know that interleukin-6 and 10F alpha is one of the main inflammatory cytokine during the secondary brain injury. By inhibiting or suppress the interleukin-6 and TNF alpha, it can prevent the neuroinflammatory process during the secondary brain injury. It also found that ADMSC can suppress the activation of the astrocyte and microglia through the GFAP marker and also EBA1 marker. So it also reflects that it can suppress the neuroinflammation process because one of the main injury during the secondary brain injury is neuroinflammation. And also it can suppress the nitric oxide produced during the stress oxidative process in the secondary brain injury. And in the end, it can prevent the apoptosis. As we know, because the less number of apoptosis will reflect that more neuron will live after the injury. Thank you.
Certainly, yes. Okay, yes, right. Okay, we have quite a very understandable explanation. Thank you very much. I think this is one of the basic mechanisms behind the secondary injury. So thank you very much for the comments.
Thank you.
Wishing you success. Thank you.
Thank you, Professor.
Thank you. Thank you, professors, for your valuable discussions. And we'll open and we'll take questions from the audience, please. So if you have any questions, please raise your hand. And yes, Dr. Vladimir Kalyushka from Ukraine. Hello.
Hello.
Yes, you can ask.
Hello. Hello, Yoko Sensei, Professor Alexander Wozniak. Thank you so much for invitation. I have thank you for your great talk, Professor Kusuma. I have a question. How do you think adipocyte-derived mesenchymal stem cells can they differentiate into neural-like cells, and then make some progress in restoration of brain function and neuroprotective effects, or they just create some anti-inflammatory media and decrease neuroinflammation? And if yes, what factors influence on differentiation to neural tissue?
Thank you for the question. So this adipocyte-derived mesenchymal stem cell is a multipotent, has a multipotent capacity. So when this cell is implemented, we put the cells in a certain niche environment certain niche environment. So in the brain, there are a specific environment, they will produce, the surrounding cell will produce cytokine that makes the adipocyte cell will differentiate into neuron. Like that, there are a lot of factors and still need to read deepen again. And in general, the niche the environment of the cell will make the specific cell type grow into neuron like that. It's the niche, the environment. Thank you.
Okay, thank you. And also one question, have you make some investigation of how they differentiate to these mesenchymal stem cells? How are they differentiating in neural-like cells after you place them into the brain, into the brain?
Yeah, actually, myself haven't tried to make a specific study to learn about the differentiation, but I think we have a lot of previous study that has been studied this, and then we can use the previous literature as our basic knowledge, and we can search it from there. Yeah,
Thank you so much. Thank you so much for your great investigation. Thank you.
Thank you. Thank you, professors. So I don't see any rising from the audience. Any other comments? If no, we have also one learning point of today's section. So now I think we can turn to our one learning point session. So thank you, Dr. Kusuma. It was very interesting, and we wish all the best for your future investigations. So now, one learning point. It's my privilege to invite Professor Yasuaki Inoue from Japan to share on the key to an effective anterior temporal approach for bifurcational aneurysm tip clipping. So, Professor, please go ahead.
Okay, thank you. Can you see my screen now?
Not now.
Already. Okay.
Yes, black screen.
Okay, let me try it again. I'm gonna share the entire screen, and I'll try to.
Yeah, we see your windows.
Okay, sorry. I don't know why, but my Mac is not working. Let me do this way. Can you see it now? No?
Yes, we see now.
Okay, can you see the basilar tip aneurysm now?
Yes, clearly
Yes.
seen.
Okay, great. Okay, so before we wrap up our session, I'd like to quickly talk about the approach to the basilar tip aneurysm when we flip it. So basically, we recommend to use the anterior temporal approach, and I'm gonna present this case. This is a ruptured basilar tip aneurysm of the 38-year-old male patient, and this is a conventional left front temporal approach, but I added transzygomatic approach, and now I'm removing the clinoid process. And I usually want to do this because we can easily mobilize the internal carotid artery very easily. And now this is a formal transsylvan approach. This is SMCV, superficial sylvan vein, and this is the anterior temporal artery. And here you can see the M1 segment of the middle cerebral artery. So basically, first key point of the anterior temporal artery is this part. So here you can see that frontal lobe is now being dissected from the M1 segment. So in order to maximize the exposure of the retrocarotid system, we have to mobilize the temporal lobe. So this is the reason why we call it the anterior temporal approach. Here you can see that this is the anterior carotid artery. So we call it the anterior temporal triangle. Here you can see the internal carotid artery, M1, and here there is a very big space, and this is very important to expose the basal tip aneurysm. And another tip might be, hey, this is a rupture point. And another tip might be like, this is a PCOM, and this is a P1 and P2 junction. Now, sometimes the PCOM is in the way when you want to maximize the exposure. So in those cases, we might be able to ligate and cut it. So this is a maximum exposure to approach the basal tip aneurysm. So this is the end of my question. And now presentation. And now our hospital, my department is now open to welcome the international fellows. Although the capacities are right now very small, but if you're interested, just contact me. Thank you so much.
Wow. That's very interesting, Professor Yasuaki. So this is really interesting. Yes, clipping of the tip, the basal artery. I have never seen this kind of. Yes, I think we have some comments and insights from our discussants and from audience. Yes, Professor Alexander Wozniak or
Professor Inoue, okay, thank you very much for great video. Unfortunately, I couldn't see it in good quality due to speed of internet, limited speed. But in general, excellent technique. My congratulations, great. In case if you need the proximal control, can you use this approach in cases when you will require the proximal control of basal artery? Is it safe or not, or you will consider some more skull-based procedure to have more room for manipulations?
Thank you, Professor Wozniak, for your comment and question. Actually, for proximal control, this approach might be enough for some cases if the basal tip aneurysm a little bit higher in the location. But if the basal tip aneurysm a little bit lower, like below the posterior recliner process, then we may have to do a subtemporal approach, or even we may have to draw a little bit of the anterior pectoral approach or something. Thank you.
So I agree with you. It's really flexible. You make a decision during surgery. If you require it, you can extend it and have more space. Thank you.
Definitely. Thank you.
yes, Professor Custodin.
Yes, thank you very much for the excellent case you have demonstrated. I have very few questions. Just I would like to mention something very interesting, which probably will be an interesting historical fact. When 1987, I was a fellow at Tokyo University, and at that time I could meet Professor Sano Keiji. And Professor Sano Keiji was interested in the same idea, and he published, I think, a couple of cases of anterior temporal approach. And also he suggested, like you mentioned, that in cases we have to look a little bit upwards, we have to drop the zygoma, which was, I think, a very good, let us say, neurosurgical sense of practical understanding of how we have to reach the points. Now, my only question is, do you have any clear indications and limitations, something that can be useful for the junior neurosurgeons, in which kind of aneurysms, location, height of the bifurcation, and direction you will recommend your approach? Thank you very much.
Okay. Thank you, Professor, for your comment and question. Actually, that is a very important point. So like, if the aneurysm is located, let's say 2 centimeters above the clinoid process, then we can never see the aneurysm. So in my facility, we set a limit like 1.5 centimeters from the clinoid line. Clinoid line means the line between the posterior clinoid process and the anterior clinoid process, and that is the very basic limit. But like Professor Kamiyama may sometimes is doing the clipping for the aneurysm, so even the higher location. that is very tricky technique, so I usually do not recommend. But if the aneurysm located below the 1.5 centimeters below above the clinical process, and we can say that it is kind of easy approach. Thank you for your comment.
Thank you.
So-
Thank you. I completely
Thank you.
your comment.
Thank you. So Professor Ahmad Fuad Pirzad, please, from Afghanistan.
Thank you, Konnichiwa. Thank you for your information. You mentioned about the fellowship, how to find the detail about the fellowship, and could you please share with us the details? And okay.
Okay, thank you for the question. Actually, we just right now we're opening the fellowship, so we do not have the formal website site or something. But just give me the email, then I can how can I say give you the detail if you are young neurosurgeons interested.
Okay, I will share my email with you. Yes, thank you.
Yeah, okay, perfect. And actually, importantly, my boss in my fellowship in the U.S., we're gonna witness Dr. Ali Sultan was my boss, and have a very emotional, friendship feeling to Afghan people. Thank you.
Arigato gozaimasu.
Arigato.
Arigato gozaimasu. Thank you, Professor, for this
Thank you.
opportunity. Yes. So, any comments from the other audience? Please also, if you can also use the chat box and write your questions, and I can send it. So maybe comments from Simon, Professor Simon Ilunga, Professor Aniwaka.
Hi, Shangman. Maybe I can ask a question. Hi, Prof. Inoue. I'm Sam from Malaysia. Thank you for the interesting presentation. I rarely see this method for clipping of aneurysms. So in your opinion, this versus the traditional terminal approach, are there any pros and cons, any particular time where you choose one over the other? Thanks.
So I couldn't catch up with the question. Pros and cons and what?
Pros and cons of using the usual terminal approach versus this anterior, temporal approach.
Actually, it is very difficult to define the conventional terminal approach. So our anterior temporal approach is just mentioning the conventional terminal approach coming a little bit from the temporal side, and usually most of the time the conventional terminal approach may be mentioning the subfrontal side, like frontal side is more mobilized. So that is just coming from backside or anterior side, and there is no big difference. So we just do not say that this is different, but this is just the extension of the usual subfrontal approach. So we do not have to mention the pros and cons, but coming from of course from the temporal side, we cannot see the subfrontal side like ACOM or something. So in those areas, we have to come to the subfrontal side as well. But the very strong point of the this anterior temporal approach is we can visualize the pickup of the acroid artery or PCAM artery, or even the temporal uncus or other how can I say structures of the retrocarotid space, and that is very powerful. So especially for the clipping of the PCAM or anterior artery aneurysm, this approach is very powerful.
Okay, great. The other thing is I saw that you ligated the PCOM artery for a bigger space. Is there like a criteria for you to do that, or it definitely cannot be a fetal PCOM? Is there a size, or do you test out with your DSA first? Yeah, thanks.
Actually, that's very difficult to say that this is totally safe, But like so of course if we can avoid it, then we want to avoid it. But like let's say this is a ruptured basal-octave aneurysm, and realize we have to clip it, and if the PCAM is stretched, then we have to cut it. But before we actually cut it, we can, apply a very tiny clip, temporary clip, and then we can do a IC angiography or even the MAP or CP before we, cut it. But regardless, in some cases, we have to cut it.
Okay, understood. Thanks so much.
Thank you, Professor, for your great discussions. And so if there is no any questions, so I would like to, on behalf of ACNS Young Neurosurgeons session, I'd like to sincerely thank our patron, Professor Yokato, and our chair of this webinar, Professor Yasuaki Inoue, and our distinguished professor speakers, Professor Tomoyuki Tsumoto, and Dr. Febby, Pratama, Kusuma, and our esteemed distinguished Professor Wozniak, and Professor Karagiozov. I think if you have any comments, any talk, so you can say something. Or and I warm thank you also goes to my fellow moderators for their support, and most importantly, all of you and our participants for joining us today. And we look forward to seeing you at our upcoming webinars. And until then, stay inspired, stay connected, please, and continue our advancing neurosurgery together. So thank you very much. Thank you, and I would like to say, I don't want to say goodbye. See you soon.
Okay, bye. Thank you, everyone.
Thank you. Bye.